All right, this is chapter 23, gynecologic emergencies. All right, women are uniquely designed to conceive and give birth. Women are susceptible to a number of problems that do not occur in men. We are special, fellas. Make sure you understand that. Buying time so I put my phone charge. Okay. Anatomy and physiology. The female reproductive system includes internal and external structures. The external female genitalia, the vaginal opening is just posterior to the urethral opening. The labia majora and the labia minora are folds of tissues that surround the urethral and vaginal opening. The clitoris is at the anterior end of the labia. The anus is at the posterior end of the labia. And the perineum is the area of skin between the vagina and the anus. This is a diagram of those structures. The internal structures. The ovaries are the primary female reproductive organs. The ovaries lie on each side of the lower abdomen and produce an ovum or an egg. The fetus develops from a fertilized ovum. Fallopian tubes connect each ovary with the uterus. The uterus is a muscular organ where the fetus grows during pregnancy. The narrowest part of the uterus is the cervix, which opens into the vagina. Okay, that's a testable question. The narrowest part of the uterus is the cervix, which opens into the vagina. The vagina is the outermost cavity of a woman's reproductive system. It forms the lower part of the birth canal. And that is a diagram of those structures. When a female reaches puberty, she begins to ovulate and experience menstruation. The onset of menstruation is called menarche. Remember that. It usually occurs between age 11 and 16 years. Any female who reaches menarche is capable of becoming pregnant. Women continue the cycle of ovulation and menstruation until they reach menopause. Menopause marks the end of menstrual activity and usually occurs around age 50. Each ovary produces an ovum in alternating months. Each month, one ovum is released into the fallopian tube. This process is called ovulation. Some women experience minor cramping pain during this release period. The process of fertilization begins in the vagina. Sperm are deposited into the vagina from the male penis. Sperm pass through the cervix, into the uterus, and eventually up the fallopian tubes. When an ovum is fertilized in the fallopian tube, the developing embryo travels into the uterus. The embryo attaches to the uterine wall and continues to grow. If fertilization does not occur within about 14 days of ovulation, the lining of the uterus begins to separate and menstruation occurs. The menstrual flow consists of blood from the separating lining of the uterus and lasts about 1 week. Female hormones, produced primarily in the ovaries, control the process of ovulation and menstruation. Pathophysiology. The causes of gynecologic emergencies are varied, ranging from sexually transmitted diseases to trauma. You should recognize and properly manage female patients with any kind of abdominal or pelvic pain. Pelvic inflammatory disease, or PID, infection of the upper organs of reproduction. This is the uterus, ovaries, and fallopian tubes. It occurs almost exclusively in sexually active women. The disease-causing organism enters the vagina and migrates into the uterine cavity. If infection expands to fallopian tubes, it will cause scarring. It can result in increased risk of ectopic pregnancy or sterility. Ectopic pregnancy is pregnancy that develops outside the uterus and can be life-threatening. If infection expands to the ovaries, it can lead to the development of life-threatening abscess. Most common presenting sign of PID is generalized lower abdominal pain. Other signs include abnormal or foul-smelling vaginal discharge, increased pain with intercourse, fever, general malaise, and nausea and vomiting. Fun fact, and we'll add this, and this will be your code check-in. There's a thing that we in the medical field call a PID shuffle. So when the pelvic is inflamed, they kind of walk funny and shuffle when they walk. So we call it the PID shuffle. Text that to me, PID shuffle. Sexually transmitted diseases, STDs. They can lead to more serious conditions such as PID, chlamydia, the most common STD in the United States. This is caused by bacteria. It is usually mild or absent symptoms. Some women may report lower abdominal pain, low back pain, nausea, fever, pain during sexual intercourse, or bleeding between menstrual periods. Infection of the cervix can spread to the rectum and can progress to PID. Bacterial vaginosis. This is the most common vaginal infection to afflict women in the ages 15 to 44. Normal bacteria in the vagina are replaced by an overgrowth of other bacteria. Symptoms include itching, burning, pain, and a fishy, foul-smelling discharge. Untreated, it can lead to premature birth or low birth weight in case of pregnancy, make the patient more susceptible to other serious infections, and also cause PID. Gonorrhea. This is caused by bacteria that grow and multiply rapidly in warm, moist areas of the reproductive tract, the cervix, uterus, fallopian tubes in women, and the urethra in men and women. Bacteria can also grow in the mouth, throat, eyes, and anus. Symptoms are more severe in men than women. Women may present with painful urination, burning or itching, yellowish or bloody vaginal discharge, and blood associated with sexual intercourse. Severe infections present with cramping and abdominal pain, nausea, vomiting, and bleeding between periods. These symptoms indicate that it has progressed to PID. Untreated, it can enter the bloodstream and spread to other parts of the body, including the brain. Vaginal bleeding. Bleeding may be considered menstrual bleeding and overlooked. Possible causes include abnormal menstruation, vaginal trauma, ectopic pregnancy, spontaneous abortion, which is a miscarriage, cervical polyps, and cancer. Patient assessment. Obtaining an accurate and detailed assessment is critical when dealing with gynecologic issues. You will be able to gain only a primary impression of the problem in the field, but through patient assessment, a thorough patient assessment will help determine how sick the patient is and whether life-saving measures are needed. Anyone who neglects to consider a gynecologic cause in a woman of childbearing age who complains of abdominal pain will miss the diagnosis at least 50% of the time. Scene size up. Your scene safety. Is the scene safe? Will you need assistance? How many patients do you have? What is the nature of the illness? And have you taken standard precautions? Gynecologic emergencies can involve large amounts of blood and body fluids potentially contaminated with organisms that can cause communicable diseases. Where or in what position was the patient found? If she is at home, what is the condition of the residence? Is it clean, filthy, or wrecked? Do you see evidence of a fight? Are alcohol, tobacco products, or drug paraphernalia present? Does the patient live alone or with other people? If it's a crime scene, you may be required to testify in court regarding conditions on your arrival. Your documentation needs to be accurate and thorough. Involve the police if any type of assault is suspected. In case of sexual assault, it is important to have a female EMT to provide patient care. The mechanism of injury, MOI. In some patients with gynecologic problems, this may be easily understood from the dispatch information, such as a sexual assault. In other patients, patient history may reveal the nature of the condition. Your primary assessment, you'll form a general impression. Is the patient stable or unstable? Use the IFPO scale to determine the patient's level of consciousness. Assess their airway and breathing. Always evaluate the airway and breathing immediately to ensure they are adequate. Circulation. Palpate a pulse and evaluate skin color, temp, and moisture to help identify blood loss in a patient. If there's significant blood loss, the patient may not be demonstrating obvious signs of shock, but may still be hypovolemic. Most cases of gynecologic emergencies are not life-threatening. If a patient has signs of shock, a weak or rapid pulse, pale, cool, or diaphoretic skin, then rapid transport is warranted. History taking. Investigate the chief complaint. Some questions may be extremely personal to the patient. Be sensitive to the patient's feelings and protect her privacy and dignity. An adolescent girl may want to keep her sexual history private. For abdominal pain, ask about the onset, duration, quality, and radiation, provoking or relieving factors, and associated symptoms such as syncope, lightheadedness, nausea, vomiting, and fever. For vaginal bleeding, ask about onset, duration, quantity. This is the number of sanitary pads that they've soaked or the number of tampons they've used, and associated symptoms such as syncope and lightheadedness. Sample history. Make a note of any allergies or medications she may be taking, birth control pills, and other devices. Keep in mind that now there's implants, IUDs, the implants in the arms, all these things. These are medications. They release hormones. They release medications. So this needs to be covered when you're asking about birth control devices and meds. Ask patients about medical conditions and their last menstrual period. This will help determine the possibility of pregnancy, and also ask the patient about the possibility of STDs. Secondary assessment. This may be performed on scene, en route to the emergency department, or if time is limited, it may not be performed at all. Pertinent secondary assessment findings should include vital signs, blood pressure, pulse, skin color, and orthostatic vital signs. What are orthostatic vital signs? So those are changes in position, standing, sitting, laying down. Abdomen, is there distension or tenderness? Genitourinary, is there visible bleeding? And neurologic, what's the mental status? Your physical exam should be limited and professional. Only examine the genitalia if it is necessary to do so to treat the patient. Protect the woman's privacy. Few women are comfortable with having their body exposed. Limit the personnel present. Be an advocate for her modesty and focus your physical exam on the NOI and the patient's chief complaint. Okay. So what is modesty and being respectful? Keep these patients covered. If you do have to expose a part of their body, whether it be the breast or the vagina, you want to make sure that if it's possible, have a female do these things. Make sure that you don't have a bunch of bystanders standing around. Make sure there's not a bunch of EMS personnel. You don't need 5 firefighters and 2 ambulance people standing, at this girl's feet while you're assessing her vagina. So keep them covered. If you do have to expose them to assess it, immediately recover before you expose another part, those types of things. And only do this if it's necessary to provide patient care and to treat the patient. For vaginal bleeding, visualize the bleeding and ask about quality and quantity. Use external pads to control vaginal bleeding. Keep the possibility of hypoperfusion or shock in mind. Always ask if there's pain associated with the bleeding. Never insert anything into the vagina to control bleeding, not even a tampon. Observe for vaginal discharge. Make observations about the discharge. Ask if there's fever, nausea, and vomiting. If there is fever, nausea, and vomiting, these are considered significant in gynecologic emergencies. Syncope is considered significant. Treat as being in shock until proven otherwise. Vital signs, you're going to assess the patient's heart rate, rhythm, and quality, respiratory rate, rhythm, and quality, skin, color, temp, and condition, capillary refill time, blood pressure. Consider obtaining orthostatic vital signs if bleeding is known or suspected. Pay special attention to the presence of tachycardia and hypotension. This could indicate hemorrhagic shock. Again, orthostatic vital signs. So have your patient lay down flat, check their vital signs, wait a few minutes, have them sit up and check them again and see if there's any variation. Monitoring devices. Use pulse oximetry. Consider using non-invasive blood pressure monitoring to continuously track a patient's blood pressure. It is always recommended to assess the patient's first blood pressure with a sphygmomanometer and stethoscope. Again, there's my favorite word. Text it to me. Sphygmomanometer. All right, reassessment. Repeat the primary assessment. Reassess the patient's vital signs and the chief complaint. Identify and treat any changes in the patient's condition. Pay specific attention to the needs of your patient. Accommodate her desire for conversation or silence. Interventions. There are very few interventions with a gynecologic emergency. For vaginal bleeding, you're going to treat for hypoperfusion or shock. Keep the patient warm. Place the patient in supine position. Provide supplemental oxygen. Consider ALS intercept for fluid replacement and transport promptly to the hospital. Communication and documentation. Communicate all relevant information to the staff at the receiving hospital, including the possibility of pregnancy. Carefully document everything, especially in cases of sexual assault, the patient's condition, chief complaint, scene, and all interventions. Your emergency medical care, maintain the patient's privacy as much as possible. If in a public place, move her to the ambulance. Have a female EMT participate in the patient's care if possible. Excessive internal vaginal bleeding. Determine the cause of the bleeding. Determining the cause of bleeding is of less importance than treating the patient for shock and transporting her. Okay. Most women will use sanitary pads to control bleeding before you arrive. Use sanitary pads on the external genitalia to absorb the blood. Document the number of sanitary pads that were saturated with blood. If the woman has a tampon in place, it is not necessary for it to be removed. The external genitals have a rich nerve supply. This makes injuries to the area very painful. Treat external lacerations, abrasions, or tears with sterile compresses. Use local pressure to control bleeding. Local means that it's just right there. You apply pressure where the bleeding is. Use a diaper-type bandage to hold the dressing in place. Under no circumstances should you pack or place dressings in the vagina. Assessment and management of specific conditions. Pelvic inflammatory disease, PID. A patient with PID will complain of abdominal pain. Pain usually starts during or after normal menstruation. Inquiring about the date of the last menstrual period is important. The pain may be made worse by walking. Patients often present with a distinctive gait that appears as a shuffle. Pre-hospital treatment is limited. Non-emergency transport is usually recommended. PID itself is seldom a threat to life, but it is serious enough to require transport and evaluation in the hospital. Sexual assault. Sexual assault and rape are common in the United States. 1 in 5 women have reported being raped. 1 in 4 women will be sexually molested, often before the age of 12 years. EMTs called on to treat a victim of sexual assault face many complex issues. Issues range from obvious medical ones to serious psychological and legal issues. You may be the first person the victim has contact with after the encounter. How you manage the situation may have lasting effects both for the patient and for yourself. Professionalism, tact, kindness, and sensitivity are important. When performing your assessment, be aware of drugs used during sexual assault or rape to incapacitate a person. Inability to remember the event should create suspicion. If these drugs are still in the patient's system, you may see hypotension, bradycardia, abdominal complaints, difficulty breathing, seizures, coma, or even death. You can generally expect law enforcement involvement. Attempts to immediately gather a detailed report from the victim may cause her to shut down. If possible, give the patient the option of being treated by a female EMT. Your focus should be on the medical treatment of the patient. Is she physically injured? Are any life-threatening injuries present? Does the patient complain of any pain? Psychological care of the patient. Do not pass judgment on the patient. Protect her from judgment of others on scene. Preserve evidence. Do not cut through any clothing. Do not throw away anything from the scene. Place bloodstained clothing and anything else that could be evidence in separate paper bags. It may be necessary to persuade the patient not to clean herself. Doing so can destroy evidence. The patient should also be discouraged from urinating, changing clothes, moving her bowels, or rinsing her mouth. She will be photographed and examined by nurses trained in sexual assault examination and management. Offer to call the local rape crisis center for the patient. Getting a professional advocate to the scene may help the patient deal with the trauma. Take the patient's history and limit any physical examination to a brief survey for life-threatening injuries. The patient report is a legal document and may be subpoenaed. Keep the report concise. and record only what the patient stated in her own words. Do not insert your own opinion. Use quotation marks when reporting the patient's version of events. Focus on the facts. Bear in mind that rape is a legal diagnosis, not a medical diagnosis. And this table 23.1 shows treatment principles for victims of sexual assault. In addition to the usual treatment principles that apply to all victims, follow these special steps when treating patients who have been sexually assaulted. Document the patient's history, assessment, treatment, and response to the treatment in detail because you may have to appear in court as far out as 2 to 3 years later. Do not speculate and record only the facts. Complete the sample history objectively. Follow any crime scene policy established by your system to protect the scene and any potential evidence for police, particularly policies regarding evidence collection. If the patient will tolerate being wrapped in a sterile burn sheet, this may help investigators find any hair, fluid, or fiber from the alleged offender. Do not examine the genitalia unless there is major bleeding. If an object has been inserted into the vagina or rectum, do not attempt to remove it. Whenever possible, reduce the patient's anxiety by using an EMT who is the same gender as the patient. Discourage the patient from bathing, voiding, which is urinating, or cleaning any wounds until after the hospital staff has completed an assessment. Handle the patient's clothes as little as possible, placing clothing and any other evidence in paper bags. If the patient insists on urinating, ask the patient to do so in a sterile urine container if available. Also, deposit the toilet paper in a paper bag. Seal and label the bag for law enforcement. This can be critically important evidence. If possible, transport the patient to a hospital with specialized staff, such as sexual assault nurse examiners. Those are known as SANE, S-A-N-E, SANE nurses, who can fully evaluate these patients, perform medical and forensic examinations, and provide all aspects of medical and supportive care for these patients. All right, so this is it for this chapter. If you have any questions, absolutely any questions, text them to the group. And again, A, B, C, or D. What is the narrowest portion of the uterus? Send that to me. You guys have a good night. Any questions, send them in so we can have a class discussion about this.